the title of this talk is the lung health crisis, the Achilles heel that we didn't know we had. And let's see if I can figure out how to advance now. All right, well, I'm hitting advance and it's not advancing. There we go. Okay. Disclosures. Okay. So I told you that this, for me, was talk today, again, a little bit different than our usual, was going to be a thought journey. And this thought journey for me really began in March of 2020, which is when we all went into lockdown. And the world has obviously changed a lot since then. So what did the world look like at that point? Well, we as physicians were very concerned about our own safety. We didn't know where we were going to get gloves and masks from. We had patients quarantined on cruise ships. We were talking about how to split ventilators, how to grab ventilators out of the operating room to try to keep patients alive. We were concerned about protecting our own families. And there was a lot we didn't know about the lungs. There was a lot we didn't know about how the virus was transmitted. And we unfortunately were woefully off on the ultimate death toll that this respiratory pandemic would have. So, and even this data I think is a little bit old, but this is from the New York Times. I think globally, the number of excess deaths that we've experienced is much higher, but since the beginning of the pandemic, at least in the United States, it's been estimated that we've had at least an excess million deaths from COVID-19. So the death toll from this respiratory virus has been absolutely staggering. So the next question then becomes, what did patients with COVID-19 actually die from? And the majority from a single cause was respiratory failure. Now, certainly we all know that once one organ fails, often other organs follows. And so I'm sure even some of the deaths in these other categories were probably precipitated by respiratory failure. And in fact, the American Lung Association has determined that lung disease is actually the #1 cause of death in the United States last year. I want to let's just let that sink in for a moment. We knew that even before the pandemic that chronic lung disease was a leading cause of death, but this is the first time it was the #1 cause of death, which just for me reiterates just how important the work that we all do really is. All right, I'm still struggling with, there we go, getting slides to advance. So with that in mind, many of you know that I worked on a book last year. And so part of that process for me was really trying to figure out why are we here? Why are we here at this unique moment in time where respiratory deaths could be the #1 cause of death in the United States? How did we let this happen? I think we know or at least we think we know how the pandemic happened, but why were we not more prepared? Why were we so vulnerable? And so I really kind of went back and wanted to think about how we got here today with how it is that we diagnose and treat respiratory disease. So if we look back in history, the really sort of first major advance in the development of the spirometer was in the early 1800s by a gentleman named John Hutchinson. So the interesting thing about him was that not only was he a physician, but he was also a medical assessor. And I know many of you probably are already familiar with this, but I found it very interesting. He developed this very early spirometry system, which was large and clunky and looks nothing like the systems that we have today. But the thing that's fascinating about his work is that he coined the term vital capacity. And the thing that he was able to figure out was that his measurements actually predicted survival. He figured this out over 200 years ago. And the crazy thing is that John Hutchinson died in obscurity in Fiji, which unfortunately probably somewhat mirrors the sort of history of the spirometer and how long it's taken to get real uptake on its usage among the medical community. So I think it's kind of important to think about other areas of medicine, and in particular, other areas of medicine that have seen successes. And this includes cardiovascular disease. So at the sort of, if we think about the pathway of development for the spirometer, it's helpful to think about the parallel pathway of development for the sphygmomanometer, which actually was introduced a little bit later. But this technology, unlike spirometry, was rapidly embraced by physicians. Now, it probably helps that the individual units originally were smaller. They were portable. They could be put into a doctor's bag pretty easily. And when physicians figured out that they could combine using this device with a stethoscope, they could get both systolic and diastolic blood pressure measurements. And it sounds kind of sad to say it, but physicians liked it because it made them look cool. They were able to go into the homes of wealthy clients and demonstrate their proficiency with this, which ultimately ended up resulting in large uptake of the device, which then ultimately led to us generating lots of information about blood pressure and what it might mean. The next sort of major divergence in the road of at least the story of sort of cardiovascular disease versus respiratory medicine came with the death of President Franklin Roosevelt. So when he entered office, his blood pressure was actually recorded at 140 over 100. And our knowledge of disease was so poor at that time, he actually chose an ENT physician to be his primary physician at the White House. But over the next few years, his blood pressure continued to rise, and ultimately was recorded at 188 over 105 in 1941. And he ultimately died of a stroke and heart failure with just astronomically high blood pressures. And so the interesting thing is that after FDR's death, we saw Congress and legislators draft and pass the National Heart Act, which ultimately funded one of the probably most important epidemiologic studies ever conducted, the Framingham Heart Study. Now, Framingham was chosen because of its convenient location near Harvard and because the community was really interested in participating. And if you look at this timeline, which was actually published by a prior Michigan person, Betsy Nabel, you can see that just the incredible drop in deaths from cardiovascular disease that we've seen over the last 70 years, but it really all started with Framingham, and they were able, from epidemiologic evidence, to understand the importance of things like cholesterol and blood pressure and obesity, and then ultimately develop drugs that address those problems. But simply having that epidemiologic data and the wealth of epidemiologic data that we have with things like blood pressure really informed and sped this process. So where does that put us now? Well, in the last 50 years or so, we've seen death from heart disease and from stroke really plummet. But look what's gone on with probably the most common chronic lung disease, which is COPD. Deaths from COPD continue to climb. So many of you, or some of you, know that I sort of became so frustrated about this issue that I wrote an op-ed in the LA Times last year, just pointing out that even before the pandemic, even before all of a sudden everyone cared about respiratory disease, at least momentarily, respiratory disease was already a problem. And it was a problem for a lot of various reasons, and that's really what I've been trying to really try to understand. I think it's a problem because of, unfortunately, stigma associated with lung disease, things like lung cancer and COPD. People often view as diseases of personal responsibility, and therefore the funding has been less robust. The timelines for certain respiratory diseases can also be really long, which makes them very difficult to study. And so if, for instance, we look at the top diseases that are with drugs under investigation, you can see just sort of a list of the number of active drugs. This is data from 2017, so it's a little bit old now, but the number of drugs but it just gives you a snapshot of number of drugs in the pipeline based on disease. So as you can see, cancer tops the list, and we finally get to asthma down here, and then we finally get down to COPD down here. And so for me, this is concerning. It's also concerning when you look at pharma R&D spending by therapeutic area. If you look at COPD in particular, we've only had one new class of medication approved for COPD in 20 years. I think you would be hard pressed to find another chronic disease with so few advancements. And a lot of the money, not that we shouldn't be studying cancer, but a lot of the money is going to areas where pharma can get a quicker turnaround. So we've got a lot of problems. Now, if you look at NIH funding relative to when you look at this graph, which is disability adjusted life years on one axis and NIH funding on the other, you're going to see a significant pattern, and that is COPD and lung cancer remain outliers. We have now this data, again, is a little bit old. What if this was more current? You would see not just diseases like AIDS, but also Alzheimer's has had just a meteoric rise in funding in the last few years. And so while generally speaking, funding tends to follow disease burden, you can also see that there are outliers. Some of the positive outliers, like AIDS and more recently Alzheimer's, have done so through coordinated, honestly, public health campaigns. When you have diseases like lung cancer and COPD, unfortunately, we've been much less fortunate in garnering public sympathy. There's still a lot of stigma associated with these diseases, and I think it's really unfortunate. It's something. It's a dialogue that I think we as respiratory physicians really need to figure out how to understand and to change. We don't not treat patients with heart disease, for instance, because we blame them for eating too many cheeseburgers or other lifestyle choices. Almost every chronic disease has some kind of lifestyle choice that's simply part of the picture, and it's ultimately not helpful for us to continue to think about diseases in that fashion. Because of low public awareness, because of low funding, because we've never had a Framingham of the lung, we have a lot of patients with undiagnosed lung disease. This is data on COPD, but of the roughly 30 million individuals that we think in the US have COPD, half remain undiagnosed. And again, part of this is the U.S. Preventive Services Task Force. It's actually just was updated again, but they say the same thing every single time it comes out, which is there's no evidence to support screening for COPD in asymptomatic persons. There's really problems with this, though, and that's the fact that, first of all, this is based on lack of evidence, not negative evidence. And the second is that it assumes that we are really good at figuring out who's symptomatic and who's asymptomatic. The problem with respiratory disease is that a lot of damage can accumulate before patients develop symptoms, and patients are also really good at adjusting their activities to avoid symptoms. So we really need better public awareness and better ways of identifying patients, because unfortunately it's a bit of a vicious cycle and it just continues. So if we look a little bit more globally across sort of where we're at with respiratory disease, I focused a little bit on COPD because that's sort of my home base in the area I know the best. But if we look outside of that, how are we doing overall? Well, lung transplant survival still lags behind every other major organ that we transplant. So the first successful kidney transplant occurred in 1954, followed by liver in 67, heart in 68, and first successful double lung transplant wasn't until 1986. And even now, the median survival for a lung transplant is really half of what it is for, say, a heart transplant patient. Well, what about ARDS? And this is something that's really been weighing on me a lot. We had a lot of ARDS before the pandemic. I think the public, unfortunately, sort of has viewed COVID as being sort of this highly specific one-time thing and doesn't really realize that this is in many ways the same disease that we as lung physicians have been treating for a very long time. And we didn't have enough investment in understanding how to treat ARDS before the pandemic. And part of the reason why we had so many deaths during the pandemic is we still didn't have a lot of good treatments specifically to try to inhibit, stop, and prevent lung injury in this particular setting. Now, another huge area of just respiratory disease burden across the globe is childhood pneumonia, which accounts for 15% of all deaths of children under 5. As you can see here, it's a leading cause of death of children worldwide under 5. One of the other, I think, interesting things that we're really beginning to understand, I'm going to talk about in the second half of this talk, is that factors in childhood likely really do contribute to disease that we're seeing in adulthood. And so, in just thinking about kind of where we're at and why we had such significant morbidity and mortality during the COVID-19 pandemic, it is my firm belief that our lungs were more fragile than we ever realized. We hadn't really invested enough in trying to understand and treat lung disease before. And I also firmly believe that we have a lot more individuals in the community that either had undiagnosed full-blown lung disease or undiagnosed or just under the radar lung inflammation that ultimately contributed to the susceptibility and morbidity that we saw. So there are a couple of pieces of evidence that really point in this direction. To me, this is one of the most interesting studies that actually came out of the pandemic, looking at the excess COVID-19 cases and deaths associated with wildfire exposure in the United States. Now, it wasn't really new information that particulate matter could increase the risk for infection, but we never really had an event where we were able to capture an exposure and an outcome in such a granular way as we were able to do during the pandemic. So in the fall of 2020, out in the American West, there were wildfires raging, but we also had COVID at the same time. And researchers were able to associate the exposure to particulate matter with very specific increases, an 11.7% increase in COVID-19 cases and an 8.4% increase in COVID-19 related deaths, roughly 750 excess deaths in the region that was studied. So in real time, we're being able to understand that sort of the global health of our lungs or unhealth in this particular case, impacted by air pollution, which ultimately is associated with factors like climate change, really do make our lungs more vulnerable and more susceptible to exposure to respiratory viruses. So this is just a quick diagram outlining all of the various ways in which the lungs' integrity can be impacted by air pollution and makes us more prone to respiratory infections. And that can be impacts on the immune system, on the microbiome, epithelial cells, immune system, et cetera. So there's just many ways in which the lungs become more vulnerable. And one of the hats that I wear is a deputy editor at the Blue Journal right now. And I can't tell you the massive number of articles that we've seen just in the last year, trying just more and more and more evidence of the data linking air pollution to problems with lung health, whether that's lung cancer, whether that's COPD or asthma incidents, et cetera, whether that's respiratory infections in childhood. The data is really, really accumulating. And for me, it's highly concerning because of factors like climate change. And we know that our air overall is generally getting worse as opposed to better. This is, to me, another super exciting study that actually, and I actually just apologize, I realize I don't have a reference on this slide, not sure why, but this actually was published by our own pathologist here at the University of Michigan. And this, to me, was another really exciting study to come out of the pandemic, and to me, really eye-opening. And what they did was to look at open lung biopsies for patients with persistent interstitial lung disease following acute COVID-19 recovery. And the most important thing to note was they actually had CT scans on some of these patients before COVID, and then were able to look at them again afterwards. And what they found, that was generally speaking, was that those with the most severe lung damage with usual interstitial pneumonia on pathology actually tended to have pre-existing lung disease before they actually developed COVID-19. And the greater severity of those pre-existing abnormalities on CT was associated with more severe disease on biopsy afterwards. And so I just wonder how many patients actually had pre-existing lung disease that they did not know about, that again contributed to the morbidity and mortality that we saw across the globe with COVID-19 infections. So one of the reasons why I think this is also really important is just the emerging information that we're getting on how the lungs evolve and develop, and how many places there are that things can go wrong that haven't really been on our radar screen, because we don't measure spirometry in childhood or in young adulthood. We really only get lung function measurements when things go wrong. And I think if we're going to ultimately get to the root of the problem, this is like treating soil erosion after the soil is already gone. We're going to have to start measuring lung function and assessing lung health at a much earlier stage. So this is data coming from COPD that was published by Peter Langebeck in the New England Journal in 2015. But essentially, the sort of mind-blowing information that came from this study was that, as opposed to what we all thought from the original Fletcher-Peto curves, that everyone who gets COPD just gets it because they have accelerated lung function decline in adulthood related to smoking, and that would be the line in red, that actually in this epidemiologic study, they demonstrated that roughly half of these individuals who have airflow obstruction in adulthood actually got there because of low achieved peak lung function in early adulthood, which means that something is going wrong earlier in the process for a much, much larger swath of the population than we really ever realized. So taking it back to sort of today and where we're sitting in 2022, I've been sitting here really trying to think, well, how did we really get here? How did we get to this place where most primary care offices don't even have a spirometer? How did we get to this place where we don't assess lung health in children on a regular basis? Why haven't we made more strides like the cardiovascular community? And I was reminded of this article written by sort of one of the godfathers of pulmonary medicine, Tom Petty, and he had written an article at one point, and he says, and he actually references this Pogo cartoon, which was popular in the United States. It's about a possum who lives in the Ozarks, and in this particular cartoon, they're noting all of the junk that's accumulated in the forest. And he says, "Yep, son, we have met the enemy, and he is us." And so, trying to be somewhat introspective and trying to understand what role we as pulmonologists have played in where we're at today, and the role that we need to play in order to sort of, shape the future of respiratory health for the US and for the globe, I think the first step is that we have to be introspective. What role have we played in the current crisis? And to be honest, I think an argument could be made that we have really shrouded spirometry in sort of mystery. It can only be done in a pulmonary function testing lab. You have to get 3 highly reproducible measurements before the data can even be used. That unfortunately what this has led to is non-adoption by a lot of primary care physicians. If you think about it, we do not hold blood pressure measurements to the same level of rigor. So in order for a blood pressure measurement to be done, say as part of a clinical trial, a subject has to be waiting for 15 minutes. You would measure the blood pressure 3 times. You would do it sort of with the same level of rigor that we approach pulmonary function, but we don't do that with blood pressure. We say, okay, well, this measurement might be off, but we're going to send you home with this blood pressure cuff, and you're going to measure it 100 times at home, and then we'll get a pretty accurate assessment of where your blood pressure really sits. And I think, not that I don't love spirometry, not that I'm not a proponent of high quality spirometry, because the measurements are so good that they can predict a bazillion different outcomes. But in some cases, I think perfect has been the enemy of good and has really reduced adoption of something that I think is so incredibly important. And so I think that the real question, though, now in the last 20 minutes or so of this talk is, well, okay, fine. So here we are in 2022. What are we supposed to do now? Realizing sort of the problem, the burden that lung disease was the #1 cause of death in the United States last year. Where do we really go from here? And so what I would argue is that we really have to take a much more global approach to lung health than we have in the past. And I know that the majority of us are not pediatricians, but that's really where the education has to start. That's really where lung development starts. And really, when we are looking at individuals with chronic lung disease in adulthood, for many of those individuals, the problems actually started prenatally. And so I think we have to, as a health community, start taking a much more global approach in our thinking. And as well as the screening and the mitigation steps that are going to have to occur if we really want to truly eradicate lung disease. So what do I actually mean by that? Okay, so for me, I think about our lung health really in 3 steps. The first is what happens prenatally, then what's happening while the lungs are still developing and we're trying to get to that peak lung function, and then what we as adult pulmonologists can intervene on sort of in that adult phase with trying to reduce decline as much as possible. And so I just wanted to give everyone just a little bit of a taste of, this is not meant to be comprehensive. There's no way I can be completely comprehensive in the roughly 15 minutes that I have left. But just to give you, I think, a taste of some of the things that I think we're going to have to start thinking about. So we know, for instance, that prematurity is a major threat to lung health, particularly male preterm infants are increased risk for respiratory distress syndrome. We have seen huge advances in our ability to care for newborns and to prevent lung disease in the last, 50 years or so. But at the same time, the technology to support life at early stages is also rapidly advanced. So now we've got preemies from 24 months on, weeks on surviving. So I think it's sort of a big unknown what level of lung disease we're going to see in children of prematurity in the next, say, 10 to 15 years. I recently saw someone in clinic who was premature and reported significant respiratory difficulties as a child. And he got lost to follow-up. And I saw him in clinic, and everyone of around 50-something% predicted, had no idea that he had chronic lung disease and why he couldn't keep up with his buddies on the basketball court. So I think it is possible that we will be seeing a much larger number of patients with respiratory illness that started in childhood from factors like that. This is not just, we actually, when you look at this globally, what is a little bit shocking is not surprising. Do we have high risk and increased rates of preterm births in places like India and Africa? But if you'll notice on this slide, the United States is still in purple. So we do have kind of a surprising number of preterm births here in the United States. And it's not clear whether that's related either to just poor maternal care, and that certainly could be part of it. And it's been argued that that's part of why, for instance, we do worse than Canada. But some of that also could be due to things like IVF and advanced reproductive technologies as well. But if we ultimately do want to eradicate chronic lung disease, then we ultimately are going to have to start thinking, even as pulmonologists, about how do we more globally prevent preterm births. And there's a lot of things. Again, this is not a talk about pediatrics, but just, there's just a lot of things that can be done, and particularly when we think about it from a global sense, to improve maternal health. One of the things for me that's super interesting, though, is that there is a lot of data on in utero nicotine exposure. So the data suggests that nicotine exposure may actually promote the development of long and tortuous airways in the infant. There's also some very interesting data that vitamin C supplementation to pregnant smokers may actually help them to mitigate some of the tobacco effects if they can't stop smoking. So these are just, this is just an example of some of the kinds of things that we're going to have to be thinking about if we ultimately want to protect the lung health of the next generation. So what about during childhood? This is a paper that was published in Lancet Respiratory Medicine just a few years ago, but just shows you the huge variety of lung trajectories that can occur across the lifespan. You can have patients that are delayed that then catch up, patients that they're just slow and never ever catch up, patients that are normal but then fall off once they hit adulthood. So there are so many different potential trajectories. But again, remember, we aren't measuring any of this ever. The only time we will measure any of this is if somebody really starts to fall off up here and develops symptoms. And so it does make me wonder to what extent, underlying lung disease or chronic undiagnosed impaired lung health, again, contributes to things like what we saw during the pandemic. So, I mentioned earlier in the talk that pneumonia is a major killer of children worldwide, but there are things that we can do. Breastfeeding reduces the incidence and severity of lower respiratory tract illness, childhood immunizations, RSV infections. There's a lot of, fortunately, new research going into development of both treatment and vaccinations for RSV, malnutrition. I didn't have a chance to update this talk, but we just presented at ERS last week a big commission. If you want to check it out, it's pretty comprehensive, but it addresses a lot of these same topics. It was published in the Lancet, and it's called Toward the Eradication of Chronic Obstructive Pulmonary Disease. And while it is focusing on COPD, it covers a lot of these same topics that if we really want to eradicate lung disease, particularly at a global level, we're going to have to start looking at all sorts of other factors because it's really where lung disease actually starts. So air pollution, I've mentioned this several times in my talk, but there again, lots of accumulating evidence that previously I think we thought, well, it just contributes, say, to excess asthma exacerbations, but no, the data shows that now it's associated with for instance, COPD incidence. And so, one of the questions that you might have is, what can we actually do about this? And that would be, again, that's like a totally separate talk. But there are a lot of things I think that we can do from a public policy perspective to try to improve air quality, but also there's a lot of things that can be done to look at air quality in the home, city planning, where we put schools, not putting schools near freeways, et cetera. So we really kind of have to take a much more global and comprehensive approach to this. Now, unfortunately, global air quality is simply getting worse. There are areas that I think we all sort of know about, but even within the United States, we have certain days that are bad. We also have certain cities that have a lot of air pollution, and it's not always the ones that you think about. Even places like Salt Lake City with their air inversions, and these all contribute to poor respiratory health. This is just you a snapshot of PM 2.5 levels here in the United States. So this is again, one of the campaigns that that you may not be aware of is just something as simple as anti-idling campaigns for schools. And just getting unfortunately, I know the pandemic lines for pickup and drop off have gotten really long, but just encouraging parents to turn off the car if they're waiting, just to try to improve the air that our children breathe in their schools. There's some interesting data that if schools are near a freeway, it's associated with lower respiratory function in childhood. But if children are moved out of that environment, their lung function actually improves once the exposures have been removed. And again, just kind of bringing this up today because I think it's something that we don't often think about as adult pulmonologists. Indoor smoke, this is an area that I work out a lot with in COPD because of exposure to biomass fuels with young women and even children cooking over poorly ventilated, non-vented open fire stoves in places like China and Africa. What is really, really shocking is that if you look at some of the data, whereas we think of COPD, for instance, as a disease of 50-year-olds and 60-year-olds, what's really shocking is that they've got very young women and very young men with COPD in some of these countries due to these kinds of exposures. This just gives you an example. So for instance, in certain parts of India, non-smoker females with COPD were 65% of all patients who met criteria for COPD. So certainly globally, COPD is not just a disease of tobacco smoke. And I think we're beginning to understand all of the different kinds of exposures that can contribute to ultimately poor lung health. So, these are not things that we often talk to our patients about. There's something that I've been trying to get more educated on myself. This is not really something we talk about in medical school. This is not something we really have traditionally talked about as much in residency or fellowship, but there are a lot of things within the home that can contribute to poor air quality and lung injury. So radon, to be honest, this is a leading cause of cancer in the United States. We probably should all be talking to our patients more about whether they're having their homes checked for radon. There's like a lot of simple things that patients can do, using low VOC paints, airing their carpet out prior to installation, running the ventilator for gas burning stoves. In their kitchens, wood burning stoves actually have been associated with increased risk of COPD, particularly in women in the can cold cohort. So making sure people are using, for instance, the most up-to-date and EPA approved versions where possible. Secondhand smoke is a huge issue for children. Even here in the United States, roughly 40% of US children aged 3 to 11 are exposed to secondhand smoke. And then obviously we have the vaping crisis, which I don't even really have time to get into, but if everyone remembers that even before the pandemic, we had the youth vaping crisis epidemic, which unfortunately and frustratingly, the FDA has been really slow to regulate. They finally have made some rulings on Juul, but there's so many other similar products that are on the market now. It's really just a drop in the bucket. In 2015, roughly a quarter of high school students and 7% of middle school students had used some type of tobacco product. And unfortunately, it's really the nefarious marketing practices of many of these companies have really targeted children with flavored products, et cetera. I'll go back to that example that I mentioned earlier of the young gentleman I met in clinic who had developed lung disease in probably in infancy and didn't know it, and came into my clinic. That same gentleman had started vaping about 4 years before I first saw him in clinic. And if he had known that he had such impaired lung health, or if his mom had known, I have a strong feeling that they would have made different life choices. And so this is one of the arguments that I know that keeps coming back to me, when I say that we need to start looking at lung health earlier. A lot of people say, well, we don't have any drugs, what would you do differently? But I think we're forgetting that our patients might make different life choices. They might limit their exposures. They would have that excess knowledge. And so I do think we have to start again thinking about our patients before there are patients, and how we can really reduce lung injury before they even get to us. And then there's just all of the myriad of exposures that our patients get besides tobacco smoke. It might be cleaning products. Patients might be a nail technician. They might have just a really dusty or dirty job. These are all things that we know. We know that roughly 15% of all cases of COPD in Western societies are actually related to occupational exposures. And in many cases, I think they can actually be hidden. I want to end the talk today just with 2 slides on health disparities. I know this is something important to me as part of the reason why I started looking at COPD in the first place, and I know it's important to many of us here in the division. I think one of the things that troubles me the most is that when we look at whose lung health is more vulnerable, and I've shown you a lot of slides today, but it's children, it's impoverished areas of the world, it's people that live in rural areas, and that's not just necessarily elsewhere, that's also here within the United States. So if you look, for instance, at the states with the most amount of COPD, that being the states in green, these are some of our poorest states. This is Appalachia. This is also, unfortunately, also tobacco growing country. So some of these, if you think about, just think about our patients who undergo lung transplants here at the University of Michigan. These patients with the poorest lung health seem to be also those with the absolute least amount of resources to be able to obtain treatments and preventive treatments, and they often then end up in the absolute worst situations. When we look at where patients with COPD live, they're in rural areas. They tend to be those of the lowest income. And I think, though, that this is not necessarily just a trend for COPD, but also for chronic lung diseases in general. These, I think, and sort of how disparities impact those who have patients with lung disease. I know that everyone in our division is aware of this research, but for our guests today, this is just an example of some of the exciting research that is coming out of the University of Michigan, because this has been an area of concern for our faculty. So Tom Valley and Michael Schoding here, based on just some clinical observations that they made here, looking at clinical trajectories of patients in our ICU. We suddenly had an influx of Black residents into our ICUs that we didn't have before the pandemic. And they noted that after doing some digging into the data, that Black individuals were not getting accurate pulse oximetry measurements. So you can see on this slide, graphing oxygen saturations based on pulse oximetry versus our blood gases. And you can see that, there's greater discrepancy with Black patients having an overestimate of their oxygen concentrations based on pulse oximetry. And here in Michigan, while Black residents made up roughly 14% of our population, they made up 43% of our COVID deaths. And so I think that, again, it's just another example where we have to take a much more global approach, and even looking inside our own walls to try to understand how to deliver better care for all patients, but also preserve, respiratory health for all of our patients. I have this one last slide, I think, before we wrap up, which is I spent a lot of time talking about defense and not very much time talking about offense. But I think offensive strategies also have to be part of our armamentarium when we're thinking about a more global approach to lung health. So this is data that was published in the Blue Journal in 2017 from the Cardia study. And this analysis was led by a friend of mine, Roddy Callahan. But essentially what they found was this was a long-term study with data from ages 35, I think up to like roughly 65. And what they found was that your higher baseline fitness in young adulthood predicted higher lung function in adulthood, but that if you maintained or increased that fitness level during adulthood, those individuals actually were those with the absolute best lung health at the end of the study. So it's certainly possible that it's simply an exercise effect of having stronger muscles, and therefore they were able to blow better and do better on their spirometry. But I think there is some thinking that the exercise itself may have some anti-inflammatory effects that may also promote lung health. And I think this is a really interesting area of research. So I think my faculty have seen this before, but for our guests today, this is just a quote from my book, but I think it just kind of summarizes for me how I am currently thinking about lung health and the unique position that we have, and that is that we really need to recognize the warning signs of lung injury much earlier, and that spirometry is not just a test of lung health, but rather of human health. And I really think we have to think about it as a fifth vital sign. So again, I think my faculty know this, but just again, speaking to our guests today, this is one of the things that I'm really trying to achieve here with the division that we have, and that is that the University of Michigan really, in our pulmonary division, really be a leader in leading some of these national dialogues to not just reduce the burden of lung disease, but actually figure out how we can ultimately eradicate it, and on multiple levels. And I think, as you heard this morning, we've got faculty and researchers interested in almost every aspect of lung disease, and also figuring out how to promote lung health. So I'm going to go ahead and end it there. I did see that Colin had a comment in the chat regarding that sadly a multitude of US health statistics relative to other developed countries have always been poor, and I will agree with you. There's probably a lot of societal and cultural factors that relate to that, but that even we as lung physicians have to be cognizant of that in our approach to diagnosis and treatment of lung disease. So this, again, happy to just, I don't know if there's any questions, but really, in chatting with a lot of our applicants this morning, I know there were a lot of questions and a lot of interest in global health and health disparities. And so I want to tell you that that's really at the heart of I think of our focus and concern as a division here at Michigan.
Hey, Meilan, this is Doug. Do you mind if I throw a comment in here?
Yeah, go for it.
So I remember when the USPSTF came out with their recommendation against screening spirometry, and I read it, I was real frustrated. And when you dig deeper in it, it's part of the devil's in the details, which is how they define asymptomatic.
Yeah.
You ask people how you assess symptoms, the vast majority of people will say, well, I asked my patient, do you get out of breath? And people, I think, with lung disease don't get out of breath because they stop doing things that make them get out of breath. And I think the question that we should be teaching is not, do you get out of breath? It's, are there things that you stop doing?
Right.
Or that you avoid doing because they make your breathing uncomfortable? I think if we just do simple things like that, all of a sudden, what was once asymptomatic now is pretty identifiably, I guess, for lack of a better word, symptomatic. And then you can have an argument for, now it's not a screening test, it's a diagnostic test. It's a very different thing, but we tend to do this with a lot of screening tests where we forget, what the definition of symptoms are and aren't. So I would just throw that out there.
No, I think you're absolutely right, Doug. I mean, that's part of the reason why I've been trying to move us towards using structured questions like the MMRC and the CAT score that we now have programmed, because they do ask about activity limitations. But of course, by the time they get it, no one's going to get out of our office without spirometry. It's really how do we, and unfortunately, one of the challenges is that, I think many of you know, we published the Rethink study last week, which showed that unfortunately bronchodilators do not help people without airflow obstruction. So I think a lot of us were hoping, well, we can just go on symptoms, or, or maybe like, as you said, Doug, really probing about exercise limitation, but there might be something that we could ask without doing spirometry to try to figure out which patients are sick. And unfortunately, at least from a treatment perspective, we can't bin them all now. So then, well, if you can't, so how do you exactly find these people then? And so I think it is one of the things that we're doing is, I think some of you know, we've been working on this CAPTURE study, which is a screening tool for COPD, but it's actually combined a symptom questionnaire plus peak flow. And I do wonder about whether there's a lot of companies, for instance, that are looking at, could they diagnose abnormal lung function based on someone talking into an iPhone or breathing or blowing into an iPhone or something like that? But do we need, I do wonder whether there's a place for some disruptive technologies like that that would aid us with screening and then getting people, so we've got to have something easier to try to find these people in primary care to then, get them into figure out which patients to get into the PFT lab. I wish I had an exact answer right now. I feel like with some of the data that's come out in the last few weeks, it's just gotten more complicated.
And I can't let it go without making my usual comment about the nuance involved with electronic cigarettes. The 800-pound gorilla is still combustible tobacco. That's the symptom of the disease, which is nicotine dependence. And so people using combustible tobacco to serve their nicotine dependence would probably be better served getting their nicotine through non-combustible methods. And I completely agree with the idea that the FDA has to be better about guarding against teen uptake of nicotine dependence. An entire generation of teens that would never have considered smoking is now dabbling with nicotine dependence through these e-cigarettes. And I think those are two different things that we have to deal with separately.
Yeah, thanks for that, Doug. Let's see, I'm trying to think, I don't know who was first. Maybe Bonnie?
I go, Alex, just because I have to run to clinic. Thanks for that talk, Meilan. It was great. You mentioned spirometry as a fifth vital sign. So I was wondering if you had any thoughts about the new PFT interpretation guidelines and how they would affect diagnosis and management of lung conditions and clinical trials and all of that.
Yeah, it's really complicated. So for those of you who not pulmonologists yet, are budding pulmonologists, the ATS has just come out with some new there's a lot of debate about which reference equations to use for spirometry, and they've kind of recommended that we switch to these global equations, and it gets even kind of more complicated than that because they're trying to figure out, should race even be part of the equations or not? And does incorporating race contribute to some kind of structural bias within the system based on the reference equations that have been generated? And so it's a very, very complicated discussion, but there's lots of arguments about which equations are best, because we want, on the one hand, we don't want to overdiagnose, but on the other hand, we don't want to underdiagnose. And it is true that at least I've noticed, I don't know about everyone else on the call, but all of my patients' predictive equations are now different now that we've switched over. And I've spent a lot of time talking to patients in the last couple of months about why their lung function numbers, while the absolute values haven't changed, their percentages have changed. But some of the goals of switching to some of these other reference equations are to just better account for and capture the heterogeneity of humans across the globe. But it is a very, very nuanced discussion, because of trying to, on the one hand, capture disease that is real disease, but not discriminate, at the same time, or like I said, contribute to further ingrain issues like structural racism that might be kind of built into these equations. So I don't think that's really an answer to your question, Bonnie, but I do think that these are really important discussions that we're having on how to better assess lung health on all of our patients. Alex?
Thanks, Dr. Han. Very briefly, a question. You very elegantly laid out how the climate crisis obviously is impacting the lung health of the vulnerable patients around the globe, with changes in air quality and wildfire risk and so forth. There is some evidence that portraying the climate crisis as a health crisis perhaps is a better way to depoliticize the issue and to convey the magnitude of the problem for our patient and the population at large. I was actually just curious in your work through American Lung Association and, in the regulatory level and the policy level, are there discussions about really bringing pulmonologists more into the issue and again, portraying this more as a lung health issue specifically to really shine a light on this problem, which is so politicized and so intractable in a lot of ways in the US specifically? I'm just wondering what kind of conversations are going on that.
Well, I think maybe to look at it the other way, I think we're trying to figure out how we can make lung health everybody's issue. And so, how do we kind of change the messaging? Because again, right now, I think that unfortunately, from like a policy perspective and a funding perspective, everybody wants to bucket lung disease over here into this, well, this is just a smoker's problem. And that's really the only problem that's there. And that's really, it's kind of their fault. So let's just, what I'm hoping we do is to make everyone understand that everyone is at risk for lung disease, or at least lung inflammation, right? And so the conversations that I've been involved with some of the, whether it's GOLD or American Lung Association or COPD Foundation, et cetera, and working to try to add some, is to try to figure out every single angle that we can use to get more people on board. So if that is people that are concerned with climate change, then then absolutely, how do we cast climate change as a respiratory health issue, or even some the work that you're doing, Alex, with burn pit victims and some of the other veterans issues. How do we highlight that to just kind of get lung health issues to really to the forefront. I think with the idea being that a rising tide will float all boats. So how can we just get more attention and more focus on lung disease in general? And I think given just the huge focus that there's been on climate change and air pollution, generally speaking, although you're right, it is highly politicized. How can we kind of leverage those discussions and those policies to include some extra funding, for instance, for lung disease associated efforts? So that's a great comment. For those of you who don't know, Alex just did a lovely editorial in the New York Times on the contribution of VOCs and unfortunately in inhaled devices and how that contributes to climate change, which is another struggle that we're having here in pulmonary.